Absolutely. Are these good? Yes. Okay. No problem. Welcome, everybody, and to those on Zoom as well, because I know we have 15 to 20 people on there. My name is Marina Martin, and I am a geriatrician and the section chief for geriatric medicine here at Stanford. And I love being in the pediatrics area because I feel like pediatricians get that there are different phases of life, just like we do, in geriatrics, that it's a very unique phase of life that deserves special attention and celebration. So it's my privilege today to introduce two people who will be presenting to us today based on a talk that they gave at American Geriatric Society National Meeting last year, or this year in May in Orlando. This is Dr. Mehrdad Ayati, who I've worked with for many years. He's one of our adjunct clinical faculty here in geriatric medicine. He did his residency at UC Davis and his fellowship here in the Stanford VA Geriatrics program, and that's where we met. He has worked in many settings, so he's been an emergency room physician, a hospitalist, worked in primary care, consultative medicine. Lately has been doing a lot of medical directorship, in particular at Los Altos Subacute, where many of our patients go. And he has also written a book with his wife called Path to Healthy Aging. If you haven't read it, please find a copy. And through that and his other work, he is kind of a tireless advocate for taking better care of older adults and has spoken on NPR and KQED and locally, regionally, nationally. So many of you may have seen him speak. I'd also like to welcome Grace Nadolny. Dr. Nadolny is a geropsychiatrist, and she is the medical director of El Camino Hospital's outpatient psychiatric program for seniors. And she is also a PI on the IDEAS study in dementia. She has the wonderful background of having gone to pharmacy school, which is incredibly helpful for this kind of work. At the University of Cincinnati and medical school at Ohio State, then back to University of Cincinnati for psychiatry residency, and she did her geropsychiatry fellowship at Case Western Reserve, and then after that has worked in many health systems around the country, developing geropsychiatry programs and geriatrics programs, particularly to serve the population with dementia and non-cognitive complications of behavioral complications of dementia. And this topic, as we all know, is a very difficult one to manage. And so we really and there's not a whole lot of evidence out there that's really completely believable. So we're very lucky to have them here today to bring up this important topic and give us some guidance. Thank you very much.
Thank you so much. It's really a pleasure for us to be here to talk and have this conversation about this very difficult area of practice. I got interested in this topic when, as new faculty in an Alzheimer's disease study unit in Cleveland, I was struggling to match behaviors with treatments. And at that time, the neurologists and neuropsychologists asked me to put together a presentation to talk about what's known about the management. And 5 geriatric units and 20-odd nursing home populations, and 25 years later, I'm still grappling with gaining mastery in this most challenging area of practice. And that's the context in which I met Dr. Ayati. It was around some difficult patients, and these slides reflect our collective understanding. So thanks again for joining us for this conversation. The terms that I'll use interchangeably today are non-cognitive behavioral symptoms of dementia, behavioral and psychological symptoms of dementia, and neuropsychiatric symptoms of dementia. These occur, the current definition of these symptoms is that there are a range of psychological reactions, psychiatric symptoms, and behaviors that impair the care of a person in a given environment or cause disruption or danger. And remember that word danger, and come back to that. They can range from emotionally overreacting to stimuli, to believing and behaving as if somebody's loved ones were replaced by imposters, calling 911, climbing through the window to escape imaginary kidnappers. And I've seen all these are very much patients that I've seen. Running down the street to get to your real home. And the care issues, as you know, can range from just a refusal of medicines to absolute refusal of care. Agitated behaviors are the most difficult area. They can be verbal or physical. Worthwhile to describe them as we talk about interventions. I have no conflicts of interest to disclose, but there is no medication that's currently indicated for use in these symptoms. So therefore, there will be off-label uses of medications discussed because there is no management strategy or FDA-approved medications for these disorders. A reminder that these behavioral symptoms occur within the context of the dementias, and the dementias are defined loosely here, we won't go into detail, as cognitive decline in one or more cognitive domains based on concern and objective evidence, and that these deficits interfere with independence over a period of time, not caused by any other problem. The importance of these symptoms is because of their prevalence. They are costly, and we don't have tools to manage them. So the higher number of symptoms that a person has, the more likely they are to be placed in a nursing home. And we know that over a 5-year period, if you follow patients with dementia, virtually 97% of those people will develop psychological behavioral and psychological symptoms. The importance and burden of these symptoms was underscored in Alzheimer's index case. He described Auguste D. Over the period he worked with her as presenting as prominently psychotic. She had paranoid delusions. She had delusions about spousal infidelity. She was screaming for hours. She was uncooperative. And that really got the staff's attention. In addition, she was cognitively impaired. My task today, defined in white on this slide, is rather narrow, but perhaps selfishly, my goal is a lot broader. I'll talk about behavioral symptoms and the diagnosis and treatment and really focus in on what we're doing, the current guidelines for antipsychotic drugs. But our broader goal is to really deliver 3 messages overarching. 1, stay tuned. The management of behavioral symptoms in dementia is evolving towards non-pharmacologic, cooperative partnerships. And the evidence from the meta-analysis is most robust in this area. 0.3 to 0.4. The historical approaches we've used have not been that great. In fact, a lot of iatrogenesis results from our overuse of antipsychotics. And the path forward is really combined strategy, melding the pharmacologic and the non-pharmacologic, and really tailored to a specific situation. One caveat, I probably won't tell you anything you don't already know, but I do hope to help you deploy that knowledge more strategically so that you don't fall into the trap of medical futility as these celestial beings that have passed beyond our current realm, still talking about prophylactic use of aspirin, and that you'll begin to reach for other agents and hopefully not Haldol. A few characteristics about these behaviors. As we discussed, dementia is defined by the hallmark cognitive losses. That's what you see at bedside. They decrement at about 10% per year in that domain, but that's just one domain. The behaviors also define and are intrinsic to this diagnosis, but these are really not yet quantified in our diagnostic manuals, and this domain is measured by the neuropsychiatric inventory. I'm talking about this because there's an evolving strategy towards counting and describing these more carefully. These behaviors are unfortunately, though, so important. They're often the seminal event for at least 50% of our patients coming to a diagnosis of dementia and referral to a specialist. And I'm reminded of the Delta pilot when I was in Atlanta that brought his wife in to see me, or was referred to me, not because of her forgetfulness or her disorientation, which were also present on exam, but because she had a sleep disturbance and because she was pacing at night and trying to give food to her reflection in the window. She believed that there was a woman outside the door. These symptoms do portend a move for a lot of these patients. The more symptoms you have, the more likely you are to be institutionalized. And they disproportionately drive the cost of care up as a result of the direct and indirect costs that caregivers basically encounter. And as I said, they drive the cost of care because they cost a lot in caregiver time and resources, but also because they will dictate address. When the behaviors escalate to more disruptive, they will typically overwhelm caregivers' ability to cope. And I've seen a lot of families that invented things and had 7 or 8 children present to try to manage these symptoms, and they would end up with having to place their loved one because they just couldn't get around all the behavioral symptoms. A geriatric psychiatrist mapped these, Dr. Grossberg mapped these, the appearance and the peak prevalence of these behaviors over the course of Alzheimer's disease. And it's interesting, there's a predictability with the appearance of these over a lifetime. So you see earlier in the disease, perhaps 3 years before diagnosis of dementia is made, patients will present as perhaps a little bit apathetic or depressed. They present to a geriatric psychiatrist. They may, in the case of if they're sent to me, they'll be diagnosed as having depression and cognitive impairment. And what I would inform the family is that the cognitive impairment may or may not reverse as we treat the depression, which we will do robustly. But more significant symptoms are what typically expose the dementia to the family. So a big behavioral change for mom, if she makes mistakes in her checkbook or misses appointments, that won't quite get the kind of attention of the favorite daughter as it will if she calls the daughter on a Tuesday night at 3 a.m. and says, "Wow, aren't you going to pick me up for church? I've been waiting for you." That's when the daughter decides that there's something really wrong, and that's the disorientation phase. Thank you. Excuse me. I think I've moved beyond this. This is the time of diagnosis, is when behaviors get more disruptive and disoriented. And if you look at the timelines of amyloid protein deposition that precedes the diagnosis of Alzheimer's disease by a decade, it helps us to understand how basically these depositions might cause circuit disruption because emotional and the brain areas that control emotion and cognition are often co-located, and there's circuit disruption occurring concurrently. So it helps us understand how these subtle behavioral changes occur and seem like natural involution to patients. The geriatric groups at large in institutions such as Stanford saw the problem with the progression of these symptoms in Alzheimer's disease very unwieldy, hard to describe and manage. And they basically noted all the areas that were being impacted and decided to convene consensus conferences in the early 2000s to try to put some order to approaching the diagnosis and treatment. And I'm going to talk just for a second about that before we move on to the real focus. They offered a simplified stress model to explain behaviors and said that basically these symptoms occur when the stresses on a system at a given time exceeds patients' understanding or ability to cope. And in at least 40% of these cases, I might add that untreated medical issues are found. Patients just don't have the ability to describe what's happening to them. When they drilled down further, they saw that really what causes these symptoms occurring in any case is quite multifactorial. There's the patient factors, environmental factors, caregivers factors, but in the patient factors, there's quite a lot of neurobiology going on, and over the last few decades, the neuroimaging has revealed to us what's really happening. I would say that this goes beyond the dopamine dysregulation hypothesis. And when we reach for those antipsychotics, we're really we're hearkening back to an earlier time when people described symptomatology and doctors had 3 tools. So currently the diagnoses and managing these behaviors is basically caregivers will describe their symptoms. And it's fine if you're in the mood and anxiety arena, right? Because antidepressants are helpful for mood and anxiety symptoms in dementia as they are in other psychiatric syndromes. But when you get into the activity dysregulation and you treat those as a psychotic problem, that's where we start to get into iatrogenesis and problems. In the last 2 decades, I'm going to just skip over this, but to say that the symptom clusters have been further identified. And our focus today is the antipsychotic combinations and use of these in dementia. And today, these are off-label when used for agitation and dementia, but in 2012, around 20% of patients are found to be on antipsychotics. And 10 national professional organizations recommend against the use of these as a first-line agent. But I would say that the patients that present to me probably between 20 and 100% are on some combination of antipsychotics for poorly described symptoms. It's not a new discussion. It began in the 80s and 90s, and it's a recurrent theme. So how safe are these agents for the treatment of agitation and dementia? They do increase mortality, and they can increase metabolic syndrome and lead to stroke. Why do we continue to use it? And if so, if they can be used and if they can help, how can they be used safely? Well, they're still used because until 2010, they had the strongest evidence base of any treatment for behavioral symptoms in dementia. And the effect sizes that we were seeing, the pooled studies and the meta-analyses were in the 0.2 to 0.3 range. Why are they still used? Again, the antipsychotics were abundant. They found a lot of uses in other treatment-resistant situations in depression, et cetera. And they're basically a tool looking for a problem. We also saw that Haldol was used for behavioral episodes of delirium in the ICU. These things were carried inappropriately into nursing homes and other scenarios. And around the same time, Janssen and Lilly began to explore a dementia indication. And I was part of some of these studies and presentations. And what became known, and again, in kind of a short overview of this, is that these caused more deaths when looking at meta-analysis of 17 studies. When you looked at the drug-treated patients, 4.5% of those people died of cardiovascular and infection-related illness. Placebo-treated patients died at a rate of 2.6%. So the NIMH and the FDA commissioned additional studies and added black box warnings to antipsychotics. Ultimately, the KDAD trial was commissioned, and this study showed they compared bioequivalent doses of olanzapine, risperidol, quetiapine, and it was a multi-center study. And basically, they looked at time to discontinuation. There were not significant differences between these drugs and placebo, but there was a signal. Here's what the graph looks like. The conclusions that they made were that the efficacy in treating behavioral problems for olanzapine and risperidol were similar. They were greater than quetiapine and placebo, but adverse events, the risk-benefit ratio was very difficult to manage. Patients were sedated, confused. They did not find a large benefit with antipsychotics versus placebo, but a lot of difficulty with the safety. People turned to look at the first generation antipsychotics to see if those would be any more help. And ultimately, the mortality rate with these appeared to be no lower and possibly even higher. So the guidelines, the American Psychiatric Association took a rather pragmatic approach and wrote some guidelines in 2007. And they said, basically antipsychotics are the primary pharmacologic treatment available for the psychotic symptoms in dementia. But they said basically the findings are modest. The results are modest, 30 to 50% improvement in symptoms, the best you get. So this idea of using antipsychotics in dementia began to lose support. And ultimately, the APA put out an updated position in 2016 after they looked at a lot more data. And they basically said that though modestly effective, the use of antipsychotics is still fraught with difficult risk benefits. And the guidelines specifically say when symptoms are severe, dangerous, or cause significant distress to the patient, that's a time to consider these uses. You want to review responses at very specific timeline and look at risks and benefits before initiating them. Use a minimum effective dose and The AGS actually went one step further in their Beers criteria that they released in 2015, and they said basically don't use these unless patients are in danger of harm or if the environment's in danger of harm. The APA guidelines said taper and withdraw after 4 weeks if you don't see a response, and after 4 months if you do see a response. And basically, there was a modest to strong evidence for a few drugs, and when they talked to all the expert opinion givers, it was felt to be a consideration towards continuing to have these available at a doctor's discretion. But again, a lot higher threshold for reaching for these. Basically, the basis for their guidelines were the Agency for Health Research and Quality reports, and they reviewed that basically the aripiprazole, olanzapine, risperidone, they exceeded placebo, but they did see that there were multiple adverse events associated. So what do these look like? Again, we said the effect size was 0.2 to 0.3 in dementia. The global scores for aripiprazole were 0.2, risperidone is 0.19, quetiapine 0.13, not very impressive. The agitation score was a little bit better for risperidone, but everything helps with agitation in dementia. Psychosis, not too impressive. 0.20 was the best we got, aripiprazole for psychosis in dementia. Do they increase CVA? Absolutely. Through direct and indirect routes, mostly in the first month of treatment. Through basically increased risk of DVT, the sedation, obesity, the contributors to sedation, obesity, causing low blood pressure, 100 milligrams of quetiapine, and watch out, and inflammatory cytokines. And in some trials, basically, they also increase the risk for metabolic syndrome. So the pathway to increase risk of thrombosis and cardiovascular events, is multiple. So what should the prudent clinician do to optimize treatment effectiveness and safety? And I would say, in a sentence, turn the brain on rather than off. Remember to use acetylcholinesterase agents first, because they stave off the emergence of behavioral symptoms in dementia. Validate a patient's situation. Responding to their emotional status often helps calm the situation. You don't have to agree with the patient that the nurse is treating them badly, but you can say, wow, that was really upsetting, wasn't it? And patients often calm down. You can also do a lot of other things to distract and structure the patient's care. We'll talk about more of that with Dr. Ayati. Use non-pharmacologic strategies first. The effect size is 0.3 to 0.4 for that. Assess other factors affecting drug safety and effectiveness, like deprescribing benzodiazepines that are also on board. When medications are required, as I said, turn the brain on rather than off. Use cognitive enhancers first. When you want to remove any anticholinergics that are present. When a patient's behaving badly, takeaway message, think about using antidepressants first. I know the effect sizes are not what we'd like them to be, but on my inpatient units, I've gotten a lot of mileage out of things like Zoloft and citalopram. Reserve antipsychotics for situations where patients are in danger. Superman jumping out the window, even if he's on the first floor, is probably going to break something, and his caregiver might have a heart attack because she's so worried. The optimal doses are as listed here. One of the agents that I've found very helpful in series of patients is actually ziprasidone. 10 milligrams IM really does the trick. Not a lot of side effects. If you need to add something, and if you decide you want to add a benzodiazepine, don't do that with Zyprexa. Think about the etiology of the dementia and treat this person as if they were your mother. Imagine that they are a Lewy body patient. We don't know which of the patients will have Lewy body disease, and we don't really know the prevalence of this illness, but a lot of people suggest that it is the second most common cause of dementia. And I can tell you on my inpatient units, it was very clear to me, the patients that had Lewy body disease, and we were able to stop the antipsychotics and clean up their metabolism and get them back walking and talking again. That's your opportunity. When you don't pay attention to what's happening to the patient as a result of your treatment, you really lose the opportunity to turn things around. You want to discontinue medicines as soon as possible. 4 weeks if there's not a response, 4 months if there is a response. And ultimately, I'm just going to skip over this and go to documentation. We want to write the target symptoms down. All my patients and families get a PHQ-9, they get that too, but they also get an NPI, which is what assesses these behavioral symptoms. You want to write the target symptoms down. If the patient is at the door 5 hours a day, rattling the door, the result that you want to see is a decreased time spent rattling the door and an increased time spent in pleasurable or structured activities. Go over the education and consent with the patient and their family. Set expectations with your team to coordinate and monitor. What are you going to do to monitor the effect of this agent? And remember that the magnitude of improvement that's possible is rather modest, 30 to 50%. So it's more of a palliative approach. Reassess the benefits at different intervals. Watch for akathisia that goes undefined in many situations. See what I've done here. Okay. Taper at 1 month or 4 months. The patients who are going to have trouble with tapering are the patients that present with baseline psychosis and auditory hallucinations. Those patients are going to respond well to risperidol. They will struggle with tapers, and that was found in meta-analysis. This is a sample of the NPI. If you're going to use antipsychotics, you want to monitor at the lipids and glucose quarterly and annually, and then blood pressure, BMI, and waist circumference every 4 weeks. Ultimately, what are the final principles? And I'll close so that Dr. Ayati can tell you about what does work. You want to use your medicine as again tailored to the situation. If you're in an urgent situation, you need to use something that will be quickly absorbed. You might need to use something liquid. You might need to use an IM. You might need to use some lorazepam. That's okay. You just don't want to make it a standing order. You want to classify and clarify if the symptoms are agitation or assaultiveness, aggressiveness, urgent, non-urgent, and urgent behaviors are going to need to be responded to with more critical measures. I'm going to pass on some of these slides here and then close with my case. So one of the cases that Dr. Ayati, let me just review this one thing, which is, here's an algorithm for treating urgent escalating agitation. What I want to highlight here is just that, the kind of improvements that you want to see are ultimately, geared to the situation, the level of dangerousness, and actually the half-life of the medicine. If you've got a patient that you started on a medication and you increase the dose after a day or a half-life, you're going to end up overshooting your mark. You want to allow 4.5 half-lives to assess response. And again, use benzodiazepines cautiously. This is a case that Dr. Ayati and I both saw together. She presented to me with really a myriad of symptoms. She had visual hallucinations. She was delusional. She believed that she might not be at the right home. She was delusional about duplicative residence. Her husband might have been an imposter. She had a lot of confusion. She was on a lot of medications. I couldn't even list them all, but she was on Sinemet Nasulex, so that cautioned me. I didn't want to reach for SSRIs too quickly because that can cause problems. She had failed donepezil and memantine, but what she said to me was, life isn't worth living. I've got these memory problems. I can't concentrate. I can't read. I'm disappointed. I can't problem solve. I don't know what's going on. I don't want to feel this hopeless. but I don't want side effects from treatment either. I mean, she really had 4 categories of symptoms. And I said to her, what do you want to hit first? And she said, I won't want to be this confused. And this is a lady with a master's degree in botany, I believe. The numbers are here. Her MoCA was 21/30. So the first thing we did, even after, and I did this a lot in my practice throughout the centuries, seems like, is we started with an Exelon patch. I had her husband cut the patch because she couldn't tolerate the oral medicines. One of the entries in her chart said that she had ulcerative colitis, and I never found a lot of substantiation for that, but I was cautious as a result. So we used the patch. We did cut it into pieces, regardless of what the pharmacist would say. And I talked with with her husband about how to approach the caregivers. So the caregivers were following her in such a way as to cause her to be more anxious because they were so afraid of her falling. And so I provided him with some language. The next time I saw her, the visual hallucinations had resolved, and her husband and she said that her functioning was 30% better. She was quite engaged with reality. She was planning a trip to Santa Barbara, where her daughters lived, and she had no depression, which was one of her initial symptoms. Her husband initially at presentation said, I think my wife's depressed, but I had her, again, give me her complaints. She did have an episode of pneumonia rehab. I thought she would be delirious. But, after that, she sprung back, and I think that was Dr. Ayati's good work. And she wanted to go for Provigil. She remembered that I had talked to her about that. We did add that she did a lot better for a period of months, planned a party for a grandson that was graduating. I actually wouldn't believe any of this, except she gave me details of who was catering and who was picking up what. I mean, this woman, had a good brain. It was failing, but she had a good brain, and so we were maximizing. She then became more anxious about abandonment and suspicious, and she had started to sleep away from her husband. We decreased the modafinil, but that did not give us any benefit. And again, this was a guy with a PhD, and he was tracking things for me. She then had a urinary tract infection. And she remained anxious, and at that point we actually we engaged some Zoloft, and it did make a difference for her. But she did develop visual hallucinations of strings that have been non-problematic for her, that are not upsetting or distressing to her or anyone else. And she plays with the strings sometimes, and her husband writes me My Health Online messages about the strings, but we haven't done anything to respond to these because she has such terrible brittle Parkinson's disease that the introduction of any antipsychotic in a patient like this would be, I believe, really probably deadly. So I'm going to stop here. There's a lot more to talk about. And just in closing, I'm going to say that there is a DICE approach that was created by this multidisciplinary panel that I referred to earlier. We don't have time to talk about that, but I did start with a caveat. I'll end it with a reminder. We discussed neuronal loss, quoted guidelines, but our focus in so doing is really to minimize suffering in our patients and caregivers. So thank you. Sorry for the over time.
Thank you so much, Doctor. Okay. Charge or?
No, you don't have to.
No, okay.
And do you,
No, we're good. Yeah, we can go. Thank you so much. Yeah. Well, good afternoon. Thank you so much for being here to discuss again, and thank you for Dr. Martin to arranging this grand round. Thanks a lot, Dr. Nadolny. We started the message that definitely use of different medication, and I think the message was very clear that we really don't have a great guideline. Again, no financial disclosure from any of this medication that I'm going to talk about it right now. Quickly, I want to say the message. If you're thinking about there is a way that we can sedate our patients with dementia, is the wrong place. Probably the best ground round will be anesthesiology. Just giving some propofol and we can sedate your patient. But in reality, in geriatric psychiatry, we really cannot. And I think the message actually was very clear that the goal of the treatment will be decreasing the symptoms for 30 to 50%. If we can make it 30 to 50%, then we actually have success. It's a rare cases we can actually make it to zero. And I think that's very important to actually have expectation. I'm sure, is anybody seen any dementia patient with any of the symptoms? I think everybody in their experience that you have, one of the symptoms at least is there. But what I want to say as a geriatrician is one of the biggest challenges that we have in difference between practicing medicine and practicing about geriatric dementia patient behavior is not having a way to measure. It's so easy to just be in a clinic and to check the blood pressure or check the cholesterol level because you have a number. But when it comes to the geriatric group with the dementia problem, the main issue is what we are treating. What's the change from this week to the second week? This is why Dr. Nadolny and I were talking about having a measurement for yourself. You can create your own measurement. You don't need necessarily to go through some of the measurement. I personally like the MPI score that Dr. Nadolny was talking, and also I use a Cohen-Mansfield inventory scale that I really like this. What happened is that if you have a baseline, that for example, if your patients come to you and you say, my patients start to kicking the caregiver for 6 times per week. Now, if you start a treatment and the next week that will be 5 times per week, that means a success. That means we're going to see in the next month the number of the kicking decrease to once a week or twice a month. That means our therapy is successful. And that means that definitely we should have a baseline. Otherwise, a sentence of patient is agitated. It doesn't mean anything. And a lot of time we are as a physician, we get frustrated because we just pick up the phone and I hear patient is agitated. And again, 4 weeks later, patient is still agitated. But when you really go on the details, you see the number of the symptoms is actually get less and less. And that means your medication or whatever you're using is actually helpful. Now, this is also MPI score to Dr. Nadolny. Now, we would just want to make sure that if you agree with that, the non-pharmacologic is always superior. And the first step, that you don't need to sit there for the rest of the presentation. You can go and enjoy your afternoon. But if you have any disagreement, just want to have some discussion about it. This is always true. But I wanted to talk to you in the remaining time about evidence-based. This is a grand run. This is more academic, and we wanted to talk how much evidence is behind of everything that we talk. That's why we like to discuss about evidence-based medicine about it. And I just want to first talk about a little bit about evidence-based about non-pharmacologic way for the dementia. Because a lot of time I see that when we talk to the patient's family, we always say, oh, let's just try music therapy because it's really effective, or massage therapy is really effective. How much evidence is behind that? Have you ever talked with the family? Because we need to set the expectation this way. Some of the things, as you probably know, the sensory interventions becomes very popular. If you go to like Germany, you see a lot of dementia patients, they actually put them in the room, which they have different color, different stimulation. Evidence is really not behind that. We actually, when we review the Cochrane review of the 3 randomized trial, we see in 245, there is some behavioral actually change, but not maintained to follow-up, which is study shows that, for example, they're doing great at the time, but when you come back a week later, they are the same. And the other things they actually noticed that definitely a little bit attention, a little bit anxiety problem, the time when they are in there. Virtual reality becomes very, very popular in people, and how much data we have, very limited. Actually, the only study that has been done very well is a really mix about outcome about forest virtual reality, showing different animals in savanna and in Amazon jungle. It actually shows that people have better cognition at the time when they put the virtual reality, but they actually notice the amount of anxiety and distress is going to be higher at the time when they put the virtual reality. And again, that was in 2 facilities, was done in Australia. And again, definitely they feel happier. But then after they remove the virtual reality, they feel more anxious, and some of them, they have sundowning as well. When we come to some of the other one, like music therapy, aromatherapy, music therapy and sensory intervention in Cochrane review of some of the data shows may improve immediate agitation. But when we talk about immediate agitation, when you come here, oh, I'm sorry. Okay, here. When we come here, we see that after the follow-up for music therapy, for even sensory intervention, they don't work anymore. It means the music therapy worked for a while, and then 3 weeks later, when you're still using the same music therapy, it's not sustained on the same things. Light therapy, aromatherapy, and all other stuff is the same story. Again, don't hate me about it, but this is the Agency for Healthcare Research Program, and please keep the door closed and don't say to anyone outside. But reality is that majority of the data they actually publish, and they have the report from 2017, shows many of the non-pharmacologic, they are effective, but they are not significant, which is we talk about olanzapine, how much with placebo, quetiapine, the same thing almost with non-pharmacologic, but it still is the safest things that we go. The same thing for the aromatherapy. Just to review, I want to be quickly on that because we don't have time. 7 randomized trial has been done in aromatherapy. It actually shows no significant difference in agitation and behavioral problem, and even the ADLs. There only one trial done in lemon balm, which is better than lavender, because I see a lot of people using the lavender. But I mean, the reality is that they may be effective. Music therapy is actually effective on depression. There's no question about it. It's actually improved agitation and may reduce depressive symptoms as well, but no significant difference with the anxiety, agitation, and well-being and cognition of these people. There are some data and trials in 110 patients about massage therapy and the touch therapy at the time when they have agitation, which actually shows hand massage therapy has actually been helpful and very small. There are only 34 patients in one trial. And additional that, when they actually talk to the patient, they see the amount of their eating is actually going to be better. But these are some of the evidence that we want to say about non-pharmacologic. We just have to really discuss in details with the family that, yeah, it's not black and white, but we just want to see all the evidence behind it. Now, let's go to the doctor business, because that's the only art that we have, just prescribing medications to the patient. And that's why we're going to start what we are prescribing. Now, Dr. Nadolny started that if we have emergent situation, dangerous, which according to American Geriatric Society panel, or we can use antipsychotic. But I want to talk about some of the other medication that we may use in a very short time that we have. First of all, target symptoms, what we are treating. Are we treating depression? Are we treating anxiety? Are we treating sexual behavioral problem? We have to really find, always start low and then go slow, but go. It's really annoying sometimes. You see, we start antidepressant medication on the dose and we leave the patient on the subtherapeutic dose for a long time. There needs to be a follow-up. There needs to increase the dose as the schedule to reach to the target dose. Instruction is always important. Avoid polypharmacy. In the geriatric wards, we're always saying that, not too many medication at the same time. And again, definitely, rather than bombarding patients with multiple medication at the same time, try one medication, look at your inventory, look at your symptoms change, and then add another medication, unless if you are in crisis, which Dr. Nadolny explained to you what we can do. Set the realistic expectation. This is the most important take-home message today. If you wanted to really treat somebody with dementia, talk to the family, talk to the caregiver, educate the caregiver, and just telling them that, you know what, no matter how much we Dr. A or B prescribe the medication, it's just going to be dropped certain percentage. And if you cannot handle dementia patient, you are in the wrong business. You have to really go and do something else, because these are demented patients, and we have to. And again, I always say that amount of the caregiver should be patient is like a preschool teacher. They're dealing with the kids that they're not able to sit more than 10 minutes. They're always running around. That's why you really have to have this personality to deal with the dementia people. Antidepressant is still one of the relatively safe medication that we use. We actually have lost, so far we have almost like working on many trials that has been done, more than 400 trials, 6,000 patients that has been done. That again, looking at the depression in the geriatric population, we have different type of the antidepressant medication, as you probably know. SSRI, serotonin reuptake is a famous one, and also we have SNRI as well. We just want to quickly talk in a very limited time about what is that. Citalopram is one of the famous one. It's one of the study has been published in 2014 in JAMA, which is a CTAT trial. Is a based on randomized trial with confidence interval, including clinically unimportant differences. What happened is that they actually look at the data for around like 184 patients, placebo versus control group. They started citalopram for the 9 weeks. placebo group as well. And they're looking at what's going to be the change after the 9 weeks in these people on at least on the neurobehavioral rating scale and Cohen-Mansfield. As you see, definitely the group of the citalopram showing an improvement on the MPI score. But what happened is that after 9 weeks of trial, there's two things happen. The people on citalopram group, they have a little bit worsening of cognition in compared to the placebo group. But when we did, I didn't do it, but the people actually did MMSE, they found the MMSE score dropped 1 or 2. Well, you may raise your hand and say, hey, Ayati, 1 or 2 is not clinically significant on MMSE, which is true. But there's two things also important to know about it. The dose of the citalopram that they actually be effective was more than 20 milligram, 30 milligram to 40 milligram. And these are the dose that is not recommended by American Heart Association because of arrhythmia. But I can say personally, as my own experience, I've never seen any of my patients respond to 20 milligram. I always have to go up to 20 to 40 milligram to see some effects of the citalopram. And this is also shows on that. Quickly about some sort of the 9 trials Cochrane review on the 692 patient. They're looking at all the serotonin agent versus placebo, and also looking at the Cohen-Mansfield trial. It actually shows that there's a significant difference between the antidepressants versus placebo on the review has been done. And especially one of them is Zoloft or sertraline, which is in a target dose of 200 milligram. It actually shows is effective on Cohen-Mansfield inventory. And one of the good, and that's what we're discussing with Dr. Nadolny about Zoloft as one of the good antidepressant medication that we can use. Now, somebody going to ask me, is there any antidepressant, antipsychotic fight? Have you have any trial to see if the patients in compare of antidepressant and antipsychotic, which one is better? This is based on retrospective study has been done in around the 3,800 patients. And they're all in the range of like 80s, Alzheimer's problem. What happened is that they looking at people that have been either on antidepressant or antipsychotic, they've never been exposed on this medication at least 3 months prior to that. And they're looking to see what's the score is going to happen. And we see actually antidepressant people, they actually respond. 48% of the people, they're actually doing better. And this is one of the famous study was published in JAGS, Journal of American Geriatric Society in 2015. But what is important for people is that part, which is look at the mortality after 6 months of trying that. This is antipsychotic group, and this is antidepressant group. And what we see that actually the people on antidepressant after 6 months, they have lower rates of mortality in compare to antipsychotic. This is exactly the same discussion that Dr. Nadolny started, that definitely that can be something that as far as consideration for practice. Is there any comparison randomized between antidepressant and antipsychotic? Smaller study done in Israel. They compare citalopram versus risperidone. It's a smaller study, 20 patients on a citalopram, 20 patients on risperidone, and then looking at the data after a while that they've been on this medication. Interestingly, the group of risperidone, they actually have more adverse effect and they have to drop from the study. The citalopram, they continue. And they see, yes, the MPI score is actually decreased. Interestingly, the group of risperidone, they decrease faster. Means that for faster effect, definitely antipsychotic was more effective, but definitely citalopram was better tolerated. And again, but it's very small study, is very single center, and again, we have again high standard deviation. It's quickly in 1 minute. Somebody may raise their hand, especially the people from King College of London, and they publish in Lancet and say, hey, Ayati, you're a big liar. These antidepressants are not effective. They have a study. They actually done the very interesting study done in randomized is actually computer-generated block randomized sequence that they have placebo group, sertraline, and mirtazapine. They're looking at them for 8 weeks of the treatment. I think it's a laser point is not working, but anyway, the 8 weeks of the treatment, what they see that around the 8 weeks of the treatment, they all dropped on MPI score, means mirtazapine 7.7, sertraline group around the 8, placebo also a little bit higher than the mirtazapine. And then after around the 39 weeks, they see the mirtazapine almost the same, sertraline drops, but placebo also the same. Say, hey, Ayati, placebo was really not difference between the group of sertraline and mirtazapine. That's true. That's come up with the conclusion to many of the panel and discussion that we, again, it's just very, very difficult. There's some people that may respond, some people they may have different reaction to that. The major side effect quickly, I just want to say a lot of people know about nausea related to that. Some of you know about syndrome of inappropriate ADH, which causes low sodium. But I still wanted to say one of the things that a lot of GI doctors these days are really concerned about it is the effects of the platelet activations of the serotonin agent. It's been a report of the many GI bleeding related to the serotonin agent as well. And there's one of the discussion about post-surgery bleeding as well. And this is something that I just wanted to give the warning. SNRI, quickly, from 2014, November 2014, actually, FDA approved SNRI like venlafaxine, Cymbalta, and Prestige for the treatment of depression in people with geriatric population. But really, till today, it hasn't shown that SNRI has been effective on really treatment of agitation behavioral problem in this group. There's one small study has been done, is actually in the Grace Center in Austria. They're looking for people that have Huntington disease, and venlafaxine has been effective, but also the adverse effect is important. One of the things that is important about the myoclonic jerk, sometimes we see in the people, like you see sometimes when on the wheelchair, they moving the arms or legs with venlafaxine, there's more report of that. The other things is important that National Institute College of Excellence in London have the warning from 2013 for be careful about use of venlafaxine for people that have pre-existing heart condition because it can increase the risk of the heart problem. And also National Advisory of Canada from 2014 has advisory that mixture of the mirtazapine and venlafaxine can increase risk of the QT prolongation and also arrhythmia. Trazodone, I just want to quickly tell you about it. There's really not significant clinical trials showing trazodone. Trazodone has a 5-HTA1 effect. That's why it's a little bit sedative. It's like antihistamine. That's why it's good for sleeping. And again, what the other things about trazodone has the same side effect that serotonin agent has. It can cause hyponatremia. It can cause serotonergic syndrome. Metabolized by CYP3A4 means it's a lot of medication can interfere with the trazodone. And because of alpha-1 blocker, not only is sedative, it can increase risk of orthostatic hypotension, increase risk of fall. That's why we have to be careful. I've seen sometimes people putting on trazodone every 6 hours, and that really doesn't make sense at all for that. Mirtazapine, mirtazapine is a good medication because of really interesting effect of 5-HTA1, which has a sleep like trazodone, but it actually is a good anti-nausea medication because it affects on 5-HT2 as well. The only things about mirtazapine, Raj and Bradley did a study that's showing mirtazapine is effective on depression, but one of the health advisory things about mirtazapine is increased risk of a stroke and increased risk of the CVA. The other things that is interesting about that is because of sedative effect, it really can be delirious to people and weight gain as well. But one of the interesting things we were just talking with Dr. Nadolny before we came here about akathisia related to mirtazapine. First time was reported in Greece, second time in Italy. I personally actually saw a patient that was been on mirtazapine, started to be akathisia, was very restless, not able to see, always walking around back to the chair at the nighttime, just moving the leg like this. And then what happened is just increase the dose of mirtazapine. The second mistake was happened, they started risperidone for treatment of this agitation, which risperidone makes akathisia worse. Now, patient is horribly akathizic, and then they start lorazepam on the patient, which is not effective. But the answer was really mirtazapine. When reduced the dose, symptoms completely resolved. And these are lots of the case report about mirtazapine as well. Other things, we just have a very limited time. Really not evidence about buspirone, except the one in 2017 showing that in like 200 patients on the buspirone, they have some change on the MPI score. The dose was 22.5 minus and plus 12.5. And then the other one is about Nudexa, which is approved by FDA for pseudobulbar effect. To be honest with you, compare of placebo versus the group is only 1.5 change. And again, the price of this medication, you probably know that 60 capsule probably for a month, because you have to use BID, is $1,488. and again, is very, very expensive for people. Gabapentin, really not a clinical trial behind that, but it's still one of the good medication to use for anxiety. There was some report of vascular nocturnal agitation, which gabapentin is helpful. We were just talking before the ground round. The liquid gabapentin is one of the one that is absorbed faster. We can use it. The cholinesterase inhibitor, quickly, I want to say, if you look at the data on randomized trial, cholinesterase inhibitor, it's really not in a randomized trial. Like, for example, New England Journal of Medicine 2007 has risperidone, donepezil in group of patients, and they see placebo 19.5, donepezil 20.4. It's really not. But if the only exception is that we notice when people been on this medication and we stop that, the symptoms get worse. The agitation, behavioral problem. Definitely there's a correlation in some of the cholinergic path that we still don't know about it. That's why it's so important. When you want to stop this medication, you should be very careful. The only exception is a Lewy body dementia, as Dr. Nadolny was saying. Many of the patients has a diagnosis of Lewy body dementia, and we really don't diagnose them appropriately. They really get benefit, or the people have Parkinson's disease and they have dementia, they get benefit, which is this is a multi-center study, has been done in UK, Spain, and Italy in group of patients with Lewy body dementia. The plan was actually treat them for around 23 weeks, and they stop for the 3 weeks. And then what we see that definitely the score of agitation and many of them is getting better. Pain management, it's a very important thing. Quickly, I just want to say it shows in one of the best study has been done that a stepwise protocol shows that at 8 weeks, we have drop in the MPI score. Lithium, quickly pass on a slide, really not clinical trial, only in the case series in frontotemporal dementia. It's helpful. The only things that I want to say about lithium, we have to be very careful about blood-brain barriers about lithium. Elderly people are very sensitive. We have to stay in a low dose and gradually go up. It becomes very popular medication called zonisamide for the neurologists, for people that have Lewy body dementia. Only one case study has showing some effect. That's something people like to hear about it. Cannabinoid and again, marijuana. I just want to tell you till today, we really don't have a strong evidence showing that medical marijuana really help with the symptoms of agitation. This is the study has been done is actually in Tel Aviv, which Israel is the best place. They're doing all kind of a study for dementia with behavioral problem. They use the topical, and they use the THC around the 5 milligram, and they go up on the 5 milligram, and they see, after the 4 weeks, there is some change on the MPI score. One of the patients got worse on psychotic symptoms. They dropped the dose to 2.5. It's effective, but it's very, very still only 11 patients. The other study done in Netherlands, which showed that actually was a clinical trial, is on 1.5 versus placebo. It shows no significant difference on that. The only one, it is a case report in British Columbia, in Vancouver, about the synthetic form of marijuana, which is, you probably heard about that. And again, that case was very interesting. We don't have time to go that, but it was on Zyprexa, Seroquel, Trazodone, Gabapentin, Aricept. But what happened is they started it on the medication, and gradually after 3 to 6 weeks, they see improvement. I'm very surprised since then. I haven't seen any clinical trial or anything like that. Prazosin, very small trials showing it's effective. But again, it's still very small. There's always the issue with the blood pressure, and the study hasn't showed. ECT, that's my last slide. It's very interesting, the ECT is really effective on some of the study that they've done it. The problem is, good luck to convince any people to get their loved one with advanced dementia to get ECT done. And there's no centers. I mean, we have Stanford, but just waiting time, getting anesthesiology, get the patient admitted. Take-home point is always try to non-pharmacologic, but be honest with your patient's family about the evidence. Is there no dangerous symptoms? Always start cholinesterase inhibitor and memantine. Even still, we don't have a loss of evidence behind that, but it still is worth to try. If the symptoms persist, consider one of the antidepressant. If there's no improvement after you reach to the max dose, combination, the combination therapy, trazodone, mirtazapine. If needed urgent, antipsychotic will be the one. And avoid benzodiazepine. Please do not make cocktail anecdotal, and just don't sedate your patient. These are all we discussed. I'm sorry, we've been rushing the time. I would love to finish that, because from the United Nations, I found that it back to my home country, actually, that the humans are the limbs in the same body and from the same essence in their creation. When the condition of the time hurts one of the part, other part will suffer from discomfort as well. If you're indifferent about the misery of others, it's not deserving to call you a human being. That's true. We all at the same family, even for our demented patient. I'm sorry, Dr. Martin, we've been rushed on the time. I think so, and also the people being on over the phone. Yeah.
Thank you both. I think I'll let them take questions here if anybody has them, as well as send out slides. And if anybody has a special request for slides, please email me, marina.m@stanford.edu. Thank you both very much for covering this very important and difficult topic, and may we keep working on finding ways. Thank you.
Thank you so much.
Make sure everything's
Very
closed
kind.
so you can get it up safely. Great job.
I just kind of lost eye there.